Welcome to the Rotary Club of Fresno's Monday meeting. Happy to see all of these great faces on here. Let me begin with that we have an awesome raffle today. It's a little bit different than our typical raffle. And again, is going to throw it up on the screen here. But if any of you are interested, we're doing a cute cookie jar and cookies filled with cookies. So I would normally say, hey, take advantage of this and get your cookies to go to your next holiday party. But unfortunately, that's probably not the case this year for most of you. So enjoy the cookies yourself. Please, $1 for a ticket. You can buy as many as you would like, but we are doing some fun there. And so please take advantage of that. Let me then move on to, we have a poll question for today. I'm going to launch it right now. So of the following, which lyric song best describes your upcoming holidays? Holly Jolly Christmas, It's the Most Wonderful Time of the Year, Silent Night, there might be a few of those right now as we go into lockdown, Rocking Around the Christmas Tree, or Oh Holy Night. So we'll talk about those results here later in the meeting there, but if you can, please take advantage of the poll there. Birthdays. I love celebrating birthdays on an annual or on a weekly basis. So we have a few of them coming up. Today we have Mr. Bud Warner's birthday. Tomorrow, and I saw that he actually joined us today, but Dr. Andre Manuth, happy birthday tomorrow, as well as Patty Thornton. Patty, I think you're on a lot, but I don't know if you're on today. I haven't seen yet. And then on Wednesday, we have Darren Roses and Kara Paraki Douglas's. So happy birthday to all those folks who got birthdays coming up this week. And then moving on now to my, I guess I'm calling them Fresno famous faces, Zoom bombs, whatever you want to call them. But I got a fun one for you today. So give me a second here. It's not too often you get to meet somebody who has their own day named after them, at least proclaimed by the Fresno City Council. And so I wanted to catch this guy before he moves off to bigger, better places. And so with us today, Mr. Larry Salinas, are you on?
I am on.
Hey, Larry, how you doing?
Good afternoon, Ryan. Doing
Good
well. Thank you.
afternoon. Well, I got some cool little pictures up here. What was up next last Thursday? I guess Mr. Caprioli had a special day planned for you.
Yeah, I don't know if he just has to get rid of proclamations before he terms out, or if it was also pick up after your dog day. So, having said that, it was still a treat to be recognized by the councilman.
Yeah, absolutely. Now, Larry, it's hard to recollect because it just seems like you've been there forever, and in a good way. But how long you been at Fresno State now?
Well, this next February will be 5 years, so I'm almost at my 5 year mark. I'll miss it by about a month.
Got it. But you're going to miss it by a month because you're still going to be part of the great CSU system, but in a much different capacity.
That's correct. I'm joining Dr. Castro down in Long Beach, where the chancellor's office for the CSU system is located. Sorry about that. Dog barking is Dr. Castro. That's my text. So when the big dog barks, I have to check it. Sorry about that. I'm going to be joining him in the chancellor's office as senior advisor to the chancellor.
Oh, that's awesome. That sounds like a pretty important position, but obviously you've done an incredible job here at Fresno State. And Larry, that's one of the cool things is that you are a Fresno native, correct?
Well, I'm actually a native of Austin, Texas, but I moved to Fresno back in 1975 when I was just in junior high school and graduated from Fresno High School and Fresno City and Fresno State. So most of all of my adult career and life have been here. So I consider myself a Fresnan and a Central Valley guy, and really actually have a strong affinity to this Rotary in particular. When I was a junior in high school, then budding attorney Brad Hill, who I call the Dick Clark of the justice system, the guy never ages. He picked me out of a group of students at Fresno High School and put me into one of the most incredible experiences of my life, which was to be part of Camp Royal. And it was at that time that I met so many wonderful people that were our keynote speakers every day that we had. And one of those was Philip Sanchez, Ambassador Sanchez. And that left just an indelible mark on me from just a wide-eyed kid from Fresno that could see someone that was from Fresno, from Pinedale, reach such successful heights in his career. And in fact, serendipitously, when I came back to Fresno for this job, I had not seen Ambassador Sanchez since then, since 1979. And I was at an event for the Betty Rodriguez Library opening, and he was introduced. And so I went up to him and introduced myself, and I said, Ambassador, you don't know me from Adam, but I met you in 1979 when I was at Camp Royal. And in fact, I still have the photograph, the little Polaroid photograph of us from Camp Royal. And in fact, hold on one second. This just occurred to me. I did have it. It was still in a box that I'm packing. I'm going to go old school. I'm not the digital type right now with Zoom, but so here's the photo of me and Ambassador Sanchez in 1979. I hope you can see it.
Yep, we can see it, definitely.
Okay, and then this is the day that I met him in 2016, and so
that's awesome.
And then we had another meeting shortly after that with at the Mexican consulate's office with Rudy Zavala. And so that was really special to me. And I've kept these images up on my office wall for the last 5 years, so I can share with students here at Fresno State that are either first generation or interested in politics or law, that they can see themselves in someone like Ambassador Sanchez and in Dr. Castro, and hopefully in me. And I talk about the experiences that I had at Camp Royal. So for all of you that have given your time, your money, your wisdom to that program, thank you. Thank you from an alumni of that program, and it's very meaningful.
Well, I appreciate it, Larry. Thank you so much. Well, I think we all are extending our best wishes to both you and Chancellor-select or elect Castro in this new position. And I am certain of some point next year, we're going to be having you guys come back there to give an update and let us know what's going on with the CSU there.
Oh, I know he would be delighted to do that and stuff. So Ryan, you have my contact information. It'll stay the same. So from a scheduling standpoint, I'll be weighing in on some of that for him, helping him with strategic vision, with visibility statewide and actually nationally. And I want to point out that for those of you that may not know, the CSU system is the largest four-year system in the nation. And that automatically puts Dr. Castro on a national platform in terms of higher education issues. So we're excited about that. As I know some of you were chatting prior to the formal setup of the meeting about the pandemic, the financial and economic impacts that it's having to the state in particular. 1 in 10 CSU alumni, 1 in 10 California workers are CSU alumni. And we're hoping that as we continue to graduate more students, that they'll be part of that economic recovery for the state. It's not going to be easy, but I think we have a lot to contribute in terms of workforce, in terms of education, and economic vitality. So look to Dr. Castro to hopefully be part of the discussions with the legislature, and we're excited to see what next year holds.
And my last question before you leave here is, do they make you sign a disclosure that you can only wear red so many days of the week or something before you join the CSU? I mean, that's got to be hard to put that red down, or at least I know for Joe, it's got to be real difficult.
Oh my goodness, yes. I have so much Bulldog red, it's unbelievable, and I'm still going to wear it. I mean, they're one of 23 campuses, and I'm sure we're going to get a few hats and T-shirts along the way. But as I mentioned, I'm a proud Fresno State alumnus, and the dogs will always be special to me.
Absolutely. Well, Larry, thanks so much for joining us today. With a big round of applause for Larry there, and so glad that you are going to have this opportunity down there to not only better, I think it's going to be better for the CSU, but I think it's great and fantastic for the city and area of Fresno here. So thanks so much, Larry.
Well, thank you, Ryan. I really appreciate the opportunity and to really make a plug for my experience with Rotary here and with Camp Royal. So thanks again.
Thanks so much. Moving on, I want to give a big thank you to last week. We had John Richards organize the annual bell ringing for the Salvation Army. And so they did an incredible job of raising funds for their outreach programs. Anna's got some fantastic pictures here with all the names of the Rotarians that participated in that. So thank you guys all so much for doing that. I really, really appreciate all that John did to make this work in this very difficult year there. And I know it was very successful, more successful than we even thought from the beginning there. So it was because of all of you that signed up and were a part of it. As well, a big shout out to Kara Paraka Douglas for the after hours Zoom wine tasting last week. I know several of you participated in that. Hope you enjoyed it. And we will definitely be trying to think of other creative ways to get through this upcoming session.
Ryan, I just wanted to jump.
Oh, you're on. You went on mute. Kara, you went on mute.
Hear me now?
Yep, we got you.
I just want to jump in and thank everyone for participating. We had a terrific group, and I got a lot of amazing feedback. Everybody said they had a great time and wanted to do it again. And also to Kevin Smith at Fresno State for the wine department. He was fantastic and sent me a lot of feedback on just the fun banter going on with all of our Rotarians.
Absolutely.
Thank you all for participating, and look forward to some more fun events coming up in the near future.
Awesome. Thank you, Kara. Appreciate it. And then one more thing, Ashley Webster, I know I got you on here. You were going to talk very briefly about the CASA youth packets or kits that we're doing.
Yes, good to see everybody. Happy Monday. Miss seeing your guys' faces in person, of course, but good to see you on here. If you can believe it or not, we're doing our 4th annual warming kit project. And this year we're going to be providing for the kids of the youth of CASA. CASA of Fresno and Madera counties is a voice for abused and neglected foster children in our community. Currently, there is 2,500 foster youth in our community. So if you can believe it or not, there is 115 teenagers that need our help. So what we'd like to do this year is we'd still like to do our warming kits. We'll still have our hats, the socks, the sweatshirts, and hopefully with some of our donations, we'll be able to do some gift cards. I know that's important for some of the kids. If we can raise a little more this year, maybe $2,000 more, we might be able to throw in some tennis shoes. If anybody has any tennis shoe hookups here in town locally that we can help the local stores out while we raise money, it would be great to contribute this whole little bag together. Of course, these kids, it's a hard time of year anyways, but they could surely use it. So I kindly ask if you guys could join myself and the rest of the Rotary Club and give a small donation for these awesome kids. That would be so great. And Merry Christmas and Happy Holidays to you guys. Good to see everybody.
Thanks so much, Ashley. And there's a quick, if you don't mind answering the question in the chat, we could get that answered, and that'd be fabulous. Thank you so much. And for those of you who want to join or add to this great cause, please just let Anna know there and we can add it on to your next bill. And with that said, we're going to jump now to our speaker. As a reminder for anybody that wants to ask a question to the speaker, please just throw it in the chat box on the right-hand side there, and we'd be happy to take as many questions as we have time for at the end. But with that said, I am now going to hand it over to our fellow Rotarian, David Alamam, who is going to introduce our speaker.
Thank you, President Ryan. It's my pleasure today to introduce Dr. Alfred Valles. Dr. Valles is a Valley native, having graduated from Fresno State, go Dogs, with a BS in biology and physiology and a minor in chemistry. Upon graduation from Fresno State, Dr. Valles attended the University of Wisconsin-Madison Medical School. After receiving his MD degree, Dr. Valles was accepted to the prestigious Mayo Clinic in Rochester, Minnesota for his residency in internal medicine, followed by a 3-year fellowship in general cardiology, followed by a 2-year fellowship in interventional cardiology. Dr. Valles is board certified in internal medicine, cardiovascular disease, as well as interventional cardiology. He has received numerous awards, including the Herman and Gwendolyn Shapiro Research Grant, the John Kimberly Curtis Award, and the Attitude and Commitment to Excellence Award while at the Mayo Clinic. Dr. Valles is currently president of the Heart Group here in Fresno, and he has been a part of that group since moving back to the Valley in 2012. Since practicing here in Fresno, Dr. Valles has been awarded the Excellence in Patient Care Medical Executive, as well as a Champion in Care Physician Award. He has numerous publications. I've got them all here, too many to list, but I can tell you that they're extremely complex. Rotarians, we're extremely blessed to have someone of Dr. Valles' qualifications and skills to be practicing here in Fresno. Now that there is one thing that I did find out about Dr. Valles is not on his CV that we might can ask him about, it is his career as a hard-hitting linebacker for the Kerman Lions. And I see where he was good enough to play in the 1991 North-South annual high school football game. So something you may not have known, and I'm sure many of those you guys out there may know Dr. Valles as a patient or whatnot, but Dr. Valles is a family man. He and his supportive wife, Selena, have 2 daughters and a son that attend Clovis schools. In the spirit of teamwork and family, Selena has been quite helpful in the early years in raising the family and helping sell real estate while Dr. Valles was in residency and fellowship in Wisconsin and in Minnesota. And she is currently selling real estate here in Fresno as well. Dr. Valles is going to speak to us on the coronavirus and effects on the cardiovascular system. However, he also gives us an update on what he's seeing locally and with the recent lockdown and increase in hospitalization rates. Maybe give us an update of as to the minute what's going on. So, fellow Rotarians, help me and welcome Dr. Alfred Valles.
Dave, thank you so much. Yeah, it's been a while since high school and that game you mentioned. Are you able to hear me here?
Yes, we can.
All right, great. Well, I got to say, it's quite an honor to be here with everyone, and I'm looking forward to sharing some of the up-to-date information with regard to COVID and cardiovascular disease here in our community. So I've been a part of Zoom meetings before, but I haven't actually had to run the screen here. So I'm going to attempt to share my screen with you. Maybe somebody can tell me if that's working.
Yes, it looks like you have COVID in your heart. It's working.
Okay, perfect. Okay, so the coronavirus is a virus which we all have become quite aware of, especially because of our current situation. But I'm going to kind of go through a bit of a background about what the virus is, how it functions, how it infects us, the symptoms that it gives, and how it can affect the heart in particular. And then hopefully I'll save some room for a couple cases of patients I've helped care for in the recent past, and we go over questions with you. And I'm going to try and move quickly because there's a few slides here that more than we actually needed here. So what is the virus? What are the symptoms? What are modes of transmission? How can we reduce our risk and exposure? And some of the cardiac complications, and then some optimism about herd immunity and the vaccinations which are on the horizon, and how those things that can affect our community. That'll be the topics of the talk today. So the coronavirus itself, what is it? Well, it's actually not an individual virus. Coronavirus is a group of viruses. These coronaviruses have been implemented in even the common cold. There's been several other outbreaks of the coronavirus in the past, and it gets their name from the corona radiata that surrounds our sun. So these proteins that stick out from the virus give a look like a corona radiata of our sun when you visualize this under a microscope. So here's a electron microscope view of the virus. This gives you an idea where that name comes from. Typical symptoms are cold-like symptoms. Of course, we know that this can progress to involve the lungs and pneumonia and a quite sick presentation. But in general, it's a cold-like syndrome, which you would notice in the beginning of an infection. It's thought to originate in China from an omnivorous wet market. These are markets where live animals are kept and butchered in front of a patron who may pick a animal for their meal, and it's thought that the aerosolization of those fluids could lead to infection. There is a propensity of coronavirus to do what's called a zoonotic drop, so it can use a bat as a reservoir. So these bats, they can be colonized with virus but not be sick, and then that in turn can lead to a secondary infection. And in this case of the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 COVID-19 virus, a particular intermediary is thought to be the pangolin, which is basically a anteater-like animal that has these hairy scales, and then it makes the jump into a human. Now, unfortunately, there was the New Year's celebration, and just as it is here in China, there's a large gathering, and that led to person-to-person transmission and eventually spread to the rest of the world, and the rest is history. Now there is a lot of controversies over what exactly happened there, and I won't disclose my conservatism too much, and so we'll just move on from there. So basically, the virus enters through mucous membranes such as the nose and mouth, and it uses a type of receptor, which is like a key-like structure called an angiotensin converting enzyme 2 receptor. Those are found in cells predominantly in the respiratory tract, but they're also been found in other tissues, especially with regard to this talk in the heart itself. Essentially, that virus latches on to this receptor and infects the cell. The cell actually then makes virus. And I think that's a salient point which is lost on many. The viruses are actually manufactured by our own cells. These viruses have a genetic code which infiltrates the nucleus of each cell, and then we generate viral particles in tissue. So we're making this virus in our bodies. It's different than a bacteria which replicates itself. The symptoms, as we know, involve the cold-like symptoms and especially shortness of breath when pneumonia is a part of the presentation. So how do we avoid exposure? That's basically our first line of defense, and kind of urge people to just pay attention to the way they feel and who they've been in contact with. So, you know, if you have any kind of illness, and especially if you have a cold-like syndrome with associated loss of smell or taste, that would be a reason to be tested. And currently testing is pretty avidly available. In fact, my wife and I just had our test done this morning, and we were able to attain a rapid response and have our final negative diagnosis within about 45 minutes of being testing. So that's something that's available in the community. Personal protection. So face masks, a lot of controversy over whether those work, but predominance of the data does suggest that it does work. And, you know, when you think about it, we don't really have data to support the use of parachutes, but, you know, we think they probably work. There's no trial or data that says parachutes work, but, you know, we kind of rely on the fact that they probably do. Washing hands, especially spending time while washing hands, is important. So 20 seconds or more is kind of the current recommendations. Surfaces and the like need to be kept clean as well. If symptomatic, stay home, especially if you have fever with symptoms. And if you do stay home, it's good to isolate yourself within the home from your loved ones as best as possible. Now, those are hard things to do, but in an ideal world, we'd be able to do that. Now, what is the mortality rate in COVID infection? So, you know, this is a very difficult question to answer. And essentially, it comes down to the number who die with COVID or from COVID divided by the number who are infected. But each of those variables are kind of hard to know with certainty. So first of all, the number of infected people largely relies on them getting tested and having symptoms. So you could think of this as symptomatic infections with regard to who's being tested currently. And then the number of who die from COVID is also hard to know, because if you die with COVID, but from something other than the infection, that's considered a COVID death. And even if you were thought to be likely infected, that would be considered a COVID death. So it's really difficult to know exactly what the mortality rate is with regard to COVID and its complications. Currently, we think it's about 1% for the general population. Now, not everyone has a 1% risk of dying if they have an infection with COVID. There are risk factors that would put you at increased risk for a poor outcome. And we've all heard about those risk factors: age and lung disease, renal disease, diabetes, obesity. Those things are talked about. But now I often get asked by patients who have minimal disease. Maybe they have, their cholesterol's high, or maybe they have got their blood pressure is a little higher than normal. Those patients really aren't going to be at a high risk in comparison with those that have significant disease. People who have had bypass surgery or stents, or have diabetes with complications of diabetes, renal disease with reduced renal function. Those are the people that we think are really at a higher risk. And if you have those things, with regard to heart disease anyway, it's about a 5 times increased risk of mortality. So that's a significant difference. And why is that? Well, there's a lot of kind of hypothesis surrounding that. As mentioned, the angiotensin converting enzyme 2 receptor, it's located on tissues, including the heart. Now, at this point, we don't have clear documentation of direct infection from the virus into the heart. What we do know, though, is that an infection can affect the heart, and it's in an indirect way. For example, there's an inflammatory response from an infection that is widespread. That inflammation may lead to plaque disruption. So you have plaque in your arteries. That generalized inflammation may affect those plaques, which may lead to thrombosis or clot formation within the vessels. That's the mechanism of a heart attack. In addition, the systemic inflammatory response, which is associated with systemic infection, can lead to weakened heart muscle and arrhythmias. So heart can become weak and not squeeze well, and a weakened heart has a propensity for rhythm problems, which at times can be life-threatening. So there's direct and potentially direct implications of coronavirus infection. So I wanted to go through a few cases of people that I've seen and helped take care of in just the last couple of weeks. So the first thing I want to talk about is something called myocarditis. So, you know, doctors tend to use big words. I don't know if it makes them seem smart, but basically myocarditis means an inflamed heart. Heart is inflamed, it's irritated, there's something going on. Now, the heart has systems, including an electrical system. So an inflamed heart will have abnormalities with regard to its electrical system. And we can see those by doing ECGs. The problem with an ECG in the context of an infected heart or a heart that's inflamed is that the findings are very not specific. So you can have an ECG that looks like one thing or the other, and it may not tip you off to the fact that the heart is actually inflamed and there's a problem with that. Blood tests are often used to diagnose heart attacks. In particular, the one we use most often now, it's called troponin. It's a small protein kept in blood cells. And we look for that in the blood because that troponin really shouldn't be leaking out into the bloodstream. It's kept in muscle of the heart. And if it leaks out, that indicates there's something going on in the heart. And again, troponin elevations are very not specific. And so they don't really sense the diagnosis. Ultrasound of the heart can be used, and ultimately coronary angiograms are used. So I'm going to tell you about a patient who I met in the hospital. She was in her late 60s. She was about 68 years old. She came in, she was short of breath. She had chest pain. She was requiring oxygen. She actually ended up being intubated, and so now she's on a ventilator. And an ECG, which was obtained after being intubated, suggested that she may be having a heart attack. And this was after her diagnosis of COVID infection. So the images that I'm going to show you, they're from her angiogram. So an angiogram is basically a view of the arteries of the heart using X-ray equipment. So we fill the arteries with contrast or a dye, and that allows us to see things with X-ray equipment. So I'm going to go ahead and play this. So this is images of the left heart circulation, and these are all coronary arteries, heart arteries that have names. These are the left main, LAD, and circumflex. But the thing that's striking is basically they look normal. So the heart arteries look normal. This is the right coronary artery, and again, it looks normal. So the next thing we do is we put what's called a pigtail into the heart, and you'll see it looks like a pigtail, this little twist on it. And then we fill the inside of the heart with contrast and take that last picture. It's called a ventriculogram. That really cinches the diagnosis. So this lady has normal heart arteries, but a very weak heart. When we do the ventriculogram, we know that the heart is weak and the arteries are not the cause. And this is in a patient who has been infected with coronavirus. So this is what's called a myocarditis. This is the first entity that we're talking about. Now, this person has a very high risk of mortality because she's got a weak heart, a troponin elevation, and her ongoing infection with pneumonia. This person has more than 5 times increased risk of dying from COVID just because of having the heart involvement. And actually, she did succumb to her illness. She was in the hospital a week or two, and she did not survive. So the next kind of entity that we see is that the heart arteries can become obstructive. So that's basically the mechanism of a heart attack for all of us outside of coronavirus and infection. Heart arteries become plugged with blood clot. We call it thrombus. That leads to a reduction of blood flow to heart muscle. The heart muscle is starved of oxygen and it dies. That's a heart attack. So again, ECG changes can vary. Troponin, this blood test, it's usually elevated, but not always. And ultrasound of the heart can be used to decipher between myocarditis, the first thing we talked about, versus this one, the heart attack. So now something that has come to light is from the standpoint, here's kind of a look behind the curtain. The doctors are wondering, what do we do when we have a patient who has COVID infection who shows up with something that looks like a heart attack? First of all, not all heart attacks have the same associated chance of dying. Depends on the artery, depends on the blood pressure, depends on EKG, lots of factors that help us to decide that. So first of all, what is the chance that this person who's having a heart attack is going to die? That's the first thing you're thinking of. The next thing is, should we give this person blood clot busting medications rather than take them to the cath lab? Now, I can tell you that's not the practice in our community, but this is on the national level. People are asking themselves that question. And the reason for that is because of the sake of the cath lab staff and the nurses exposing them to patients who could transmit the infection. So you can give a blood clot busting medication and avoid taking that person to the cath lab, therefore avoid exposure to your staff. So that's another question. And then if they do go to the cath lab, what are the precautions that need to be taken? So currently everyone is gowned up. We've got head to toe coverings. There's the respirators, et cetera, that we use to take care of these patients. So this is a lady who, again, I've taken care of just in the last few weeks. So she's a 38-year-old female. She's a history of diabetes and has undergone a pancreas and kidney transplant and was doing very well, but on immunosuppressant. So she's on medicines which reduce the immune response so that she doesn't have rejection of her organs. And she unfortunately is infected with COVID virus and comes in again with chest pain and short of breath. She was actually hypotensive, so her blood pressure was going very low. She was requiring medications to increase her blood pressure, and so that's called a shock state. So very sick lady. This is her angiogram. So this time, again, the left circulation, these are the LAD and the circumflex, and these vessels look fine, but the right coronary artery just stops. That's a stump. So this is a wire that's being placed into the artery of the right coronary artery, and you can see as we're working here, opening the artery, sucking out blood clot, putting in balloons, administering medications, things are being done to try and alleviate this thrombus burden. This is what's called a thrombolectomy. I don't know that you'll recognize this, but there's a tube that's put down in the artery and we're sucking the artery out literally. And now you can see the artery starting to blossom up and open. So it turned out she did not have really any plaque burden. There was not a plaque like we would normally see in people who have heart attacks. Essentially, she had complete occlusion of the right coronary artery by virtue of a hypercoagulable condition. So people with COVID virus tend to form blood clots. And so we see heart attacks because of that. We see strokes. We see another incident called a pulmonary embolism. So she's actually done great. I saw her in the office and she is just doing awesome. It's as if she never had the problem. So she did great. The next thing is DVT and pulmonary embolism, so deep venous thrombosis, so blood clots in the leg, and those blood clots can go into the lungs. And again, another patient who presented with chest pain and shortness of breath. He was 66 years old and diagnosed with COVID about a week prior to his presentation. And we did a CT scan, and this is a still shot from the CT scan. The arrow points to a filling defect. So this is the pulmonary artery on the left, and it's almost occluded completely with a blood clot. So pulmonary embolism is another thing that we see. And this is just kind of running through the video so you can see the rest of it. So those are the main things I wanted to talk about with regard to what we're seeing from a cardiovascular system standpoint. I also want to just touch bases quickly with regard to the viral vaccines which have come up, and this is a whole novel way of making vaccines, so I find it quite interesting, and it's just ingenious the way they've done this. So these messenger RNA vaccinations are really something. So basically, the virus has a protein code which is used to generate those spikes that stick out from the virus. This is what's called messenger RNA. So we've replicated that messenger RNA and wrapped it in a lipid or a fat, oily covering. That fat, oily covering and the protein which codes for these little spikes are wrapped up in, that's basically what the vaccine is. So this lipid covered protein is injected and it'll fuse with our own cells membrane. Our membranes are also lipid or fat, so they fuse there. That protein code is then, it makes its way into the cell. And then we have something called a Golgi apparatus, which will kind of copy that and make these proteins. So you have viral proteins which are being made, not the virus, but just those outpouching proteins. Those proteins can make their way to the surface of our own cells, and they're recognized there by our immune system, and that's how we stimulate an immune response. So these are called T cells. T cells kind of help augment this whole thing, and then B cells actually are what makes our antibodies. So you have this whole process of making antibodies to these proteins without actually having to be injected with a live or attenuated virus. Most of the vaccines which have been available to this point for other conditions are basically live or attenuated virus. And this is not that. It's a small protein which instructs our own cells to make these spike proteins. And this is just ingenious way of doing things. And the other, I think, important thing to know about is that messenger RNA, that small protein, does not make its way into our own nucleus. So there's kind of talk on the internet about this is basically like a GMO for people, and it really isn't that. This messenger RNA is actually destroyed within a short amount of time, and it doesn't make its way into our nucleus, so it does not affect our genetic code. The Pfizer and BioNTech vaccine was the first to make its way through the phase 3 trial. It had 43,000 participants and 170 COVID cases. So of the 170, 8 were in the people who had received the vaccination. The rest were in the people who had received the placebo arm. That amounts to about a 95% effectiveness rate. That is huge. And the safety is very good. The side effects, which exceeded about 2%, included things like fatigue, site pain, things like that. Not to minimize those things, but we don't see this often with vaccines. And I'll show you how this compares to other vaccines, which are currently available for other conditions. So here's the, in dark blue, this is the COVID-19 vaccine, the Pfizer BioNTech vaccine. The ones that are just adjacent to it include things like chickenpox and polio. Imagine what vaccines have done for polio. And this is as effective as that vaccine. This is just amazing that we have been able to come up with this vaccine in such short order and have it be that effective. And so far it looks safe. So, you know, I have people asking me about whether they should take the vaccine or not. And I guess my response to them is that I'm going to be right in the beginning of the line, and I'm hoping that they will be too, because I think this is about as good as data as we're going to get. And this is very exciting to see. In addition, Moderna, another company, partnered with the National Institutes of Health and came up with a vaccine, which is basically the same mechanism of using messenger RNA. This study had 30,000 applicants. 196 people in the study had COVID symptoms, and 11 were in the study group, and only one of the 11 in the study group actually had severe COVID. So it's really exciting. So about a 94% effective rate. And both the Pfizer and the Moderna vaccinations appear to have the same effect in people regardless of age, gender, or ethnicity. So it's as effective in elderly as well as the younger that were included in these studies. So it's really good news and nice to see that. So now that kind of brings me to one of my major concerns. And it turns out my major concern isn't that obvious, I don't think. It's about the people who don't show up to the hospital because they're afraid of getting infected. I've seen this a lot. I've got a lot of stories I'd like to share. So, you know, there's a man who, he's 66 years old. He came to the emergency department through emergency medical services, actively receiving CPR. So basically what that means, he had a cardiac arrest at home, and the EMS arrived and had to start pushing on his chest, giving him oxygen, trying to shock his heart. Very sick with a massive heart attack. He came to the emergency department. We took him immediately to the cath lab. He had a major occlusion of the artery in the front of the heart called the LAD, otherwise known as the widowmaker. We were able to get the artery open, but he required a pump called an Impella, which helps support the blood pressure. He ended up with several stents, LAD, along with some other arteries that were occluded. He spent a week in the ICU on a ventilator, and then eventually I got to meet him. And I say I got to meet him because I haven't been able to talk to him at all. And with COVID, no family members are allowed in the hospital. And so we're kind of on our own in a way. And I said to him, so what happened? What was the story? And he said to me he had chest pain for about 2 weeks prior to his coming to the emergency department, but he was fearful of getting infected. So he's sitting at home having chest pain, and he didn't come in because he didn't want to get COVID. And so that's actually one of my major concerns, is all of the people who aren't presenting for care because they're concerned about contracting COVID. And, you know, the hospitals have done a lot of work to try and isolate people with diagnosis of COVID, and they're quarantining and moving people into areas which are isolated from those who show up to the ER with chest pain, for example. I have seen several patients with a very similar story. And this is some data that actually highlights that. So this is done in the Massachusetts area by a guy named Deepak Bhatt. He's a researcher at Johns Hopkins. And what this graph is sort of highlighting. So if you look along the top, the blue solid line, that's people who had heart attacks in 2019. And what you'll notice is it's sort of a steady state. There's a certain amount of people who are going to have heart attacks, and that's been the case for years and years. But when you look at the red solid line, that's people who presented to the emergency department with heart attack. So it dropped off quite a bit. You see, it just fell down. And the reason for that is isn't because they aren't having heart attacks, because they're having heart attacks. They're just having them at home. And when you think about a heart attack and the fact that it has between a 50 and 80% mortality rate, so 50% to 80% of people who have these kind of heart attacks, they're going to die. So the mortality rate in those patients who don't come to the hospital and seek care is exceedingly high. And we're losing a lot of people in our community this way. St. Agnes Hospital, Clovis Hospital, I go to both of those frequently, have both seen this phenomena. So there's people in our community who are at home having heart attacks and they're not getting seen. That is a big problem. Also, when it comes to other conditions, so for congestive heart failure, for strokes, for several cardiovascular diseases, we've seen the same phenomena where there is less and less hospitalizations for these conditions, but we know over years and years that there's a steady state that you can expect that there will be a certain amount of people presenting, but now because of COVID, they're dropping off. And I've seen real examples of this. So that's actually one of my main concerns. And so with regard to our current situation in the hospital and hospitals, we're kind of at a tipping point. It's starting to become a big problem. In fact, just this morning, I received a message asking that any elective cases be deferred. And it's hard to know what an elective case is when you're a cardiologist, because I always say, you know, I'm no toenail doctor, and that's because I could care less about toenails. They fall off, nobody dies because their toenails fell off. But when it comes to the heart, it's an important organ, and we've got patients who need care, and we're being asked to determine who can wait and who can't wait, and that's tough to do. And that's because our resources are being stretched here in Fresno. My alma mater, Mayo Clinic, had 1/3 of their staff infected. That was as of November, and it's probably more so than that now. So Amy Williams, who's a nephrologist there and the dean of clinical practice, made an announcement regarding this in the end of November. I have lots of colleagues and coworkers who have either been infected or are forced to quarantine because of exposures and things. So when we talk about ICU bed capacity, I think it's easy to think about it in the way of how many beds we have, how many ventilators we have. But I think the rate limiting step actually comes to how much staff you have. And this has been a problem in our community even before COVID. I'll have a patient who I'll take care of, and I'll think that they need to be in the ICU for one reason or another. And it comes to an explanation. I have to explain, well, why do I think they need to be in the ICU? And that's because it's a commodity which is hard to come by. And it really comes down to people to take care of patients rather than facilities like beds or ventilators, at least in our town at this time. So as an example, in Fresno County, there's 149 licensed ICU beds. And this was as of Friday, this last Friday. So 58 patients are in the ICU currently with COVID infections. There's only 5 beds available in Fresno County. I had a patient about 3 weeks ago presented John C. Fremont Hospital, which is a critical care access hospital up in the mountains. They have about 4 beds in their ER. She presented there with what's called heart block. So she's having a very low blood pressure and she needs to get emergently to a hospital. I could not accept her in Fresno. There was no bed available to accept her in care. She ended up having to go to San Jose. And I've been in touch with her family. We're trying to get her transferred here, but we haven't been able to do it. So there is a real shortage, but it really comes down to staffing. And in Fresno, it's difficult to recruit people, and doctors and nurses both. That's something that I hope to change. I guess I'm biased. I grew up here. I love it here. I can't see why people don't want to move here, but it's tough, and we do have a shortage. It's actually considered an underserved population here in our town. So, so this is kind of some examples of some of the things that we're wearing. Guy on the left, that's Dr. Javed, partner of mine. That's me in the middle as well on the right. And we use different kinds of equipment according to whatever we're thinking we're going to come in contact. So I just wanted to stop here and kind of come up. Anybody have some questions or things you'd like to discuss?
As you would probably suspect, there's a ton of questions, and I'll try to rattle these off to you. We'll kind of make it a quick one here, but one of the first questions was, and I think you semi-answered it, but just what is the status update for the vaccines coming to this region?
Yeah, so I think that's an excellent question and on all of our minds. Phase 3 trials have been completed. We've got really good data. The vaccinations are going to be, they're going forward. There's doses which have already been made, and the infrastructure is in place where to store. All these messenger RNA vaccinations are fragile, so they have to be kept in a cold environment and refrigerated. Valley Children's Hospital has been selected as a place to house these viruses in our community. And basically at this point, it's a matter of prioritizing who gets the initial round of vaccinations. There is basically going to be a tier of who gets them initially, starting with healthcare workers. And then there's a debate from there. I don't know that that's been decided. I think there's a legitimate argument that our valley needs to be considered high on that list because we feed the entire world essentially. I think 3 of our counties lead the list of fruit producers, and the food chain and supply is important. So of course I'm advocating for our community, but I expect that this vaccination will start rolling out probably at the end of this month, the first part of January, and probably it'll be healthcare workers first.
Yeah, no, thank you. I thought this was a great question here. This virus seems to be more complex than the other SARS in the past. Any thoughts on a man-made additive or component to this infection?
Yeah, so I kind of alluded to my conservatism in my thoughts. I honestly don't think so. I think that there is a legitimate question about how this virus got out and whether it began in a lab or whether it began in a wet market. So the bat, which was the initial reservoir, there's some genetic material which was looked at, and that type of bat has not been known to be housed in a wet market. There is a lab in Wuhan which has that. Now, I guess my thought is probably it was not that on purpose that it was released, that it was something that was released inadvertently. And I don't think that there's a man-made component that would make it more virulent. If you actually look at MERS, the MERS SARS virus, that had a much higher mortality rate than does COVID. And the initial SARS-CoV-1 also. So it's not as deadly, which is actually, if you think about it from the standpoint of the virus, it's to the virus's advantage not to kill everyone that it infects, because then it can't spread out as much. So you want to kill, if you're the virus and your objective is that you survive to replicate, you don't want to kill all your hosts. So it is less virulent than MERS. MERS had a 30% mortality rate, just for some context.
Yeah, no, great. This is a good question that came out last week. Last week, researchers reported finding that the China virus is in most U.S. blood samples taken from blood donors about a year ago, December 13th to the 16th, 2019. How long would the virus have been circulating in the U.S. for that to happen?
Oh, yeah, I'm not sure, but there are some retrospective studies that look like it was probably at least in since December.
Yeah. Do they know if the risk of heart complications continues after recovery from the virus?
Yeah, so that's a good question. Actually, there are some data that says to answer that question. So there's so you can do an MRI of the heart just like you would of any organ. And there was a study done looking at MRI of the heart in patients who either were infected with COVID with symptoms or without. And it turns out that there is evidence of inflammation in the heart in those patients, and that those have been associated with rhythm problems, especially. So fast or slow heart rhythms. And I have seen a patient who is suffering with that now. So fully recovered, young girl, in fact, she's in her 30s, fully recovered and came in because of palpitations, which likely are related to a previous infection.
And that goes to the next question, which is, it's not just heart, but we're seeing a lot of other long-term effects. And I think this is going to be something that we're going to be seeing, I'm assuming, for years at this point, correct?
Yeah, I would say that that's also an important thing to consider and think about. So it isn't just who dies from it, but how it impacts your life and your quality of life. When you have a significant pneumonia, you lead to scar formation in your lungs and something called fibrosis. So I've got a patient who had a pneumonia, was hospitalized, was able to be discharged and is doing well, except that when he walks, his oxygen saturation drops. Oh, wow. And he feels well, but he can't do anything because he gets up and moves around, his oxygen drops. So he needs oxygen for that. And there's several people I've seen with scar and things that lead to that. So there will be long-term ramifications of illness, and it isn't only those that die that are impacted.
And I thought this was a great question, because I think it was the most recent I had heard it was 3 months, 3 to 6 months. But what is the most recent data on how long the immunity lasts if you are vaccinated? Is it still largely unknown?
Yeah, I would say that's not known. These two viruses, they're given in 2 doses. So there's the first dose, which introduces the body to that antigen. And then there's a second, it's kind of a booster. And I guess the thought is are we going to need boosters to maintain immunity? And that's not known.
Yeah. And I think you alluded to this question a little bit earlier, but there's been some publicity that the COVID-19 is being blamed for other deaths when there are other factors in play. Can you speak to the issue of how a death is indicated on a death certificate when there's COVID and another factor that is related to the death?
So when I kind of touched on the mortality rate, I kind of alluded to that problem. So if you have a COVID infection, but you die from some other cause, it's a COVID death. And that's because there's not a lot of resolution in that. In order to have that kind of granularity, you'd have to comb each of the medical charts and things. And we're talking a national level that these data are being followed. So if you have a COVID infection and you die from something other than COVID-related complications, it's still a COVID death. And in fact, if you have suspected COVID, so if your doctor feels, yeah, you probably have it, but it hasn't been confirmed and you die, that's still considered a COVID death.
Yeah, okay. Almost wrapped up here. Is there an anticipation for rollover of benefits for those that are able to postpone elective medical procedures to 2021? And elective being in quote unquote.
Yeah. I'm not sure I understand that question. So I guess it has to do with coverage.
Yeah, yeah, deductibles, max spending accounts, all that. I haven't heard nothing from a congressional level at this point, but
yeah, I don't know of anything to suggest that would be great. I mean, it makes sense, right? That could be done, but I don't know of anything to suggest that's going to be the case.
I think this is on the newer side, but the governor announced that Apple and Google are working on an app. Will this help?
I don't. I mean, it may. It's nothing I would sign up for.
Yeah, exactly. And I think the last question you did answer already, but if you had COVID, how long are you immune to get it again? And we don't know that answer at this point.
No. I guess you can measure your antibody titers, basically the concentration of antibody in the bloodstream over time, and that may help, but we don't have that data.
Yeah. Well, great. Well, any closing remarks? That's it for the questions.
Yeah, I just wanted to make sure and reiterate, I guess the main concern I have in this environment is that if you're sick, you need to see your doctor, whether it be from a heart attack or a stroke or something else. I've talked to others. I have colleagues that are in general surgery and they're seeing patients with appendicitis at home, and and they're waiting and waiting, and by the time they get to the hospital and get care, if they get there, they're very sick. These people, so I guess I just want to reiterate the importance of seeking medical attention for any symptoms which may be concerning. Don't wait, and don't stay home fearful that you're going to contract COVID and die from a heart attack.
Yeah. Well, fantastic. Well, thank you so much. I think this was thoroughly enjoyed by everybody, knowing that it's the hot topic of the day. Okay, you're getting your virtual clap. I'm sorry you don't get to hear it, but hopefully you get to see it. But Dr. Valles, thank you so much. Although you are a Kerman Lion, I'm a Washington Panther, so a little bit of a rivalry sometimes, depending on the sport. But thank you so much for joining us today and giving us this great information.
Thank you very much. All right, take care now. Bye-bye.
Fantastic. And moving on, we have our results of our polling. I just shared them there, but it's kind of spread all over the board, but Silent Night did win it. And that's probably very appropriate considering the year right now. So thank you for all those of you who were able to fill out today's poll question. Mr. Dick Harrington, we have a recognition for today.
Yes, we do. Thank you very much, President. And recognition, Ted Falk, if you're still on the line, could you unmute and get on board? Ted?
Yep, I didn't know that I was going to be on.
Well, you are, because I understand it's your 10th anniversary of joining the Rotary Club of Fresno. And I know over the years that you participated heavily in Project Nino. Can you tell us a little bit about that participation?
I think Dave Hodge can tell you a heck of a lot more about it, but it was an experience to go down to Mexico and help some of these people in various villages and what have you. And they've actually improved their lifestyles, and we move on to other villages. So I have not gone in the last couple of years, but I understand. I don't know what's happening on the COVID-19 thing, if we're shut down and visiting that area anymore. But yeah, we did a few. It was mostly surgical procedures and simple restorative things, but and a lot of preventive things. And we did primarily treated children and young people. So it was quite an experience.
Well, on behalf of the club and particularly on behalf of the patients you treated, thank you for your participation in that project. That is more than a worthwhile endeavor that all of you undertook. So I know that you've already told Anna how much you wanted to be recognized for, and on behalf of the club and on behalf of the community for which those funds will be used, again, I thank you very much.
You're more than welcome. My pleasure.
Ryan?
Got it. Thank you so much, Dick. Thank you so much. Let me see here. Moving on, Mr. Tim, I think you're still on, aren't you?
I'm here. Yes.
Fantastic. You want to tell us about next week's fabulous speaker we have?
You bet. Happy to. Thrilled to have a friend of mine, Eric Proch. He's with Microsoft. He'll be joining us next week. Eric is the Senior Director of Public Affairs for Microsoft, and he is leading their journalism initiative. As many of you know, the local news business has gone through historic, profound change the past few years with digital disruption, past few decades actually. And Microsoft certainly recognizes this and has put this initiative in place to help address that. They understand and recognize and appreciate the importance of local news to healthy communities and our democracy. So excited to have Eric here next week to talk about that initiative. Fresno actually has been selected as one of 6 markets across the company that they will be investing in, both money, technical resources, training, and the Fresno Bee will be participating in that. So you'll learn a little bit more about that and what that means to our community next week.
Well, fantastic. Thank you, Tim. Look forward to that. Moving on, Anna, it's time for who gets to sugar today. So who's going to win those cookies?
All right, well, thank you. We've got famous cookie jar from Shirley Grace's collection and cookies. We'll have another cookie jar next week too. So thank you. This helps fund our club projects such as the Marjorie Mason Center, Boys and Girls Club. And today's winner is Dave Haddon.
Congrats, Dave.
And next week we are going to have, for anybody who wants to have a good time, we're going to do some fun. Get out your holiday sweaters, get your ugly sweaters, get your antlers on. We're going to decorate around the room, share a little bit about show and tell for holiday spirit.
Awesome. Well, fantastic. Look forward to that. And with that said, thank you all for joining us once again. Hope you had some fun. Although we're remote, we're still doing what we should as Rotarians there. So it's great to see all of you. Thank you once again. Have a great rest of the week. See you next Monday.
Shahadi, are you still on?